here to talk a little bit about CPR. So just take a moment and put yourself outside of the veterinary hospital and imagine that you are a dog trainer, an obedience trainer that is out on a field with a group of your clients and the student dogs that you are going through a session with. And all of a sudden you hear somebody say, help, my dog just fell over. I don't think he's breathing. Do you know what to do? And this is something that actually happened. And somebody caught a video of it, and it was a news story that went all over the place. But with that said, this is footage of the dog trainer jumping in to perform CPR. What do you think? The dog's definitely not breathing. What do you think about his CPR technique? Poor chest compressions? Yeah, I would agree. The dog just took an agonal breath, so it's looking at the mouth, making sure it's not occluded, giving some kind of a breath. Then he goes back to compressions. Not fast enough, not consistent. Any CPR is better than no CPR. I agree with that. Not fast enough. Yeah, so when we take a look at that, we could definitely critique how he's performing CPR. But with all that said, the dog comes back. Looking nice and pink. Disoriented, but aware. He's like, no, thank you. I just almost died. I don't need water. Gotta go see a doctor, something like that. But this is how it ended up, that this trainer jumped in. And whenever I talk about this, I make sure that I mention that he is a hero, right? That he knew whatever he knew about how to perform CPR in an animal, or maybe nothing at all, and knew what CPR looked like in people, and kind of did what he thought needed to be done. But he took the opportunity, he jumped in, he tried to help the animal the best that he can. So he truly is a hero. So I don't want to knock that at all. And I want to make sure that that is recognized. But with that said, if we knew exactly how to perform CPR, would that have been different? Now, CPR in the veterinary practice might look a little bit more different. And so maybe it'll look more like this. Does this look more like CPR in your hospital? Yes and no. And I think most of the time when people say no, it's because they say, we don't have that many people. Oh, there you go. Wish we had that many people. And so we have a relatively large hospital. It's a 24/7 hospital that has a staff of 150 or so, not all at once, but with that said, there's a good number of people. So we call it a code overhead, and there's a lot of people that come by and are able to help. But with that said, there's medical equipment, there's more staff, the ability to intubate, all of that. You're not just out in the field stuck on what you need to do with what you have. And so it might look more like this. Or does it look more like this? Where you get the epi, hook up the ECG, get a tube in, do we have an IV yet? And then do it all now. And you hear that slow motion, spit flying all over the place, low voice, yelling and things like that going on. Is it chaotic like that? And hopefully not. But with that said, while all that's going on, do we have any questions about how CPR should be performed? How much epinephrine do we need to get? What does the ECG really show us? And then with all that going on, what should we do first? And so the effort that over 100 specialists took to take a look at all the literature out there to answer as many of these questions that we had about how to perform CPR, putting it together as a guideline, is what RECOVER is all about. RECOVER is the reassessment campaign on veterinary resuscitation. And in 2012, there was a evidence-based guideline that was published that can be used by veterinary professionals to adapt it into a protocol within their hospital. And that's what we're going to talk about today, the RECOVER guidelines. The RECOVER guideline really comes down to this algorithm, and it can really, all of that could be summarized into this one page. It starts with the very top, where you find an unresponsive apneic patient and performing something called an ABC assessment. We check the airway to make sure it's patent, see if the patient is breathing, that's why it's AB, and then the C is in quotes because if you took the A, B, and C, which one of these is not as important, do we think now? And that's actually C. C stands for circulation, where we would be auscultating the heart to see if there's a heartbeat, we would be palpating for the pulses to see if there are pulses. But with all that said, we know that in a high stress emergency situation, medical professionals, even medical professionals, can't detect pulses as accurately as they think, that they could think that there is a pulse when there isn't one, or the other way around 40% of the time. So you can make a mistake in terms of whether there's a, detecting whether there's a heart or not. And so by just doing the A-B assessment, at the point that the animal is not breathing, you can assume that the patient is arrested or they are about to arrest and go on into performing CPR. Then we move on to initiating CPR and starting CPR as soon as possible, which is very important that we don't delay. And that CPR starts with basic life support. Basic life support consists of chest compressions and ventilations. And performing chest compressions for 2 minutes is considered that compression cycle. In that first compression cycle, we should be adding on the advanced life support measures, such as initiating monitoring, which we'll talk about a little bit more down the road, obtaining vascular access, and administering reversals should we need to do so. And there's 2 minutes of compression that goes on during that time. And once that is done, we evaluate the patient. So then we move down to the lower area here that indicates the flow of CPR going forward. So just think about that first 2 minutes of basic life support fitting in right here. We're performing, number one, basic life support, chest compressions for 2 minutes, providing ventilation, and setting up the patient. And then once that 2 minutes is up, we always evaluate the patient. Has the patient come back? We check the ECG as well. And if the answer is yes, the patient's back, has achieved ROSC or return of spontaneous circulation, that's great, we got the patient back. And we would move on to the post-cardiopulmonary arrest algorithm to try to get the patient out of the hospital now. But many of the times, the patient would not have come back, which takes us to this area over here, the third step, which would be split into the A side or the B side, the left side or the right side, depending on what kind of ECG rhythm that we might see. And there's a few different things that we'll do, which we'll cover down a little bit later in the presentation. But once that's done, we move back to performing compressions, performing ventilations for a 2 minute cycle, and then reevaluating the patient again, and then reacting to what the ECG says and what the patient's doing. And depending on the rhythm, we'll do those left or right pathway, go back to 2 minutes, evaluate. 2 minutes of compressions, evaluate. 2 minutes of compressions, evaluate. And we do that over and over until, hopefully, we get that return of spontaneous circulation, which will allow the patient to survive that arrest episode and go into the post-cardiopulmonary arrest algorithm. So that's how CPR should look now. So we'll go ahead and start with chest compressions, number one over here, to talk about what that looks like. Now, the reason why the chest compressions is on number one of the algorithm is that it is truly the number one most important thing, is to create blood flow. Chest compressions should be started immediately, meaning that because if we delay on performing chest compressions, then that's a longer amount of time that the patient is left without blood flow, which will lead to poor survival. The rate of chest compression should be 100 to 120 compressions per minute. We should be pushing the chest down hard enough such that the width of the chest is compressed to from fold width to about a third or a half of the original width. So that's pretty darn hard for a large animal, but maybe not so hard with a smaller animal. In between each of the compressions, we need to allow full recoil of the chest cavity, meaning that the ribcage should spring back open as high as possible. And we perform those compressions 2 minutes uninterrupted, stopping for nothing like just trying to listen to the heart or even trying to intubate. That compression is performed on a specific compression point, which we'll talk about as well right now. And so there's a round-chested animal. This is a pretty normal looking dog that you'll see very typically around. And these guys are considered round-chested in that their chest cavity is just as wide as they are deep. And so if you take a cross-section of the chest, they're typically pretty round. In these animals, we perform compressions on the highest point of the chest. And utilize something called the thoracic pump theory. The reason why we push on the widest and the highest point of the chest is because what we're trying to do in this situation is we're trying to create intrathoracic pressure. We push down on the chest, which creates positive pressure within the chest cavity, which pushes down against the blood vessels, squishing the blood vessels down to a collapsed level, and especially the venous system because it has flaccid walls. And it pushes the blood in both forward and backward directions, but the backward direction is cut off by valves and things like that would prevent it from going backwards, and so most of the blood flow goes forward. When we allow the chest to recoil, it creates negative pressure within the chest cavity, which then pulls blood from the abdomen forward into the chest. And then we push down on the chest again, creating that same forward flow effect, and then allowing for recoil, which pulls the blood from the abdomen into the chest, and then we push down on it again, and repeat that over and over using the chest cavity as a pump. That's why it's called the thoracic pump theory. Another chest type, chest size and conformation type, is called keel-chested or narrow-chested. They are much, much deeper than they are wide, so like the greyhound, for example. In these situations, we think that the heart is close enough to the chest wall within that triangular contouring that it has towards the ventral side that we should be able to push anatomically where the heart is to use the heart itself as a pump, utilizing the cardiac pump theory. So in these animals, it would be right over the heart that we would be designating as the compression point. What about these guys, these alien-looking creatures that we very much love? These guys are considered flat-chested animals. They are often wider than they are deep. And in these situations, like us, we are much, much wider than we are deep. So we're flat-chested. In those situations, we can perform chest compressions over the sternum, utilizing the cardiac pump theory that we should be able to push down pretty directly onto the heart. But with that said, this is actually a pretty rare case. Just because it's an English bulldog doesn't necessarily mean that they're always flat. So we need to take a look at each individual's conformation and make sure that we're performing compressions at the correct compression point for that particular patient. So just as a review, a round-chested animal that looks like this, just as wide as, just as deep, or almost as similar, pretty similar in terms of the width and the depth. They're round-chested, so then the red dot designates just about where the highest point of the chest would be. Narrow-chested dogs, even a large animal like this, it would be conceivable that you could depress the heart, and so you push over the heart. What about this dog? This dog that you put on the back and can't get up. Where would you perform chest compressions on this dog? There you go. Still can't do it. So this is what I really say about animals that you think are flat-chested. If you put them on their back and they flop over and they want to flop over on their side, then they're probably not flat-chested enough. And so you would go ahead and use the lateral recumbency, round-chested conformation, thoracic pump theory, chest compressions. If you put them on their back and they stay on their back, then they probably are flat-chested, and you go ahead and perform compressions on the sternum. Now, as I was viewing this video, I thought it was really funny that this guy back here is just sleeping, doesn't care. Has this, somebody said it's like a been there, done that kind of face. But anyways, help an animal up, please. Going back to chest compressions, in terms of recumbency, whether it's left lateral recumbency or right lateral recumbency, there's no evidence to show that one way or the other is more significant or more beneficial over the other. So we say that it doesn't really matter. Whichever side that you start on, go ahead and start on. And the physical tips for performing compressions is to put your hand over your hand, make sure that your palms are overlapping each other, superimposed on each other, and go ahead and interlock your finger. Your shoulders should be directly over your hand as you rest them on the patient, and lock your elbows using your back core muscles in order to perform compressions. And so this is what that would look like. So you can see on the left side, she has her elbows locked, hand over hand. On the right side picture, you can see that you can pretty much draw a perpendicular line from the shoulder to the hand that goes into the patient, which allows you to put all the force that you put into the patient directly into the patient instead of it going sideways and diagonal. What about a small animal? A small animal would look something like this. That when they're small enough that you can use one hand to perform compressions, then you can perform cardiac theory compressions with one hand, pushing your thumb against the other ones. This cat has absolutely no recoil because it's a stuffed animal, but many of the real animals would have a little bit of recoil. But with that said, if you push too hard, their chest compliances, their chests are a lot more compliant than a larger animal. So be careful not to overcompress. Okay, and what is your favorite song that you have in your head as to try to keep the rhythm? Is it Staying Alive? Or is it Another One Bites the Dust? And we actually have a poll going in the Recover Certified Veterinary Professionals Facebook group right now to determine our own list of top 10 CPR songs. But there's a whole bunch of them out there that you can take a look at. Somebody mentioned Dancing Queen, and that's on that list as well. So there's a whole bunch of them over there. And this is actually the second part of that page that you can get by going to this website to take a little bit of continuing education, and they'll give you this list at the end of it. Yes, unfortunately, the veterinary professionals page, the Recover Certified Veterinary Professional page, the poll looks like Baby Shark may be on that list, which I don't want to put out there, but have to be true. So this is a photo of us going to Japan in January, where we went and trained a group of instructors that could carry out the Recover certification process in Japan. And it was one of the first times that we went out to another country at this kind of a scale to create sort of like a Recover Japan out there that can continue doing this. And we're trying to figure out how we can do that for the rest of the world as well at the moment. But with that said, we found that when we talked to them about, well, just sing Staying Alive in your head to keep the rhythm, that actually didn't work for Japan. They were like, Staying Alive, like, what is that? And so eventually we found a song that actually worked for them, which happened to be the Beatles, because everyone knows the Beatles, apparently. So when we were trying to use Staying Alive or something like that, it was all over the place, and it was very satisfying to see how synchronous they became once we used a song that actually they were familiar with. And then later we found out that this cartoon character called Doraemon has a theme song that is around that 100 beats per minute as well, which works really well for them because pretty much everyone in Japan knows this character. So anyhow, we are trying to spread the RECOVER guidelines and the certification process internationally because it truly should be the international standard that we follow and we spread as hopefully in the future considered a requirement for veterinary professionals. Okay, so here's what compressions for a dog might look like. Let me know what you think about this. I think it's pretty good. Forceful, compresses to about half the width, elbows locked. Yeah, she might be lifting it up as she's allowing for recoil and things like that, but very strong compressions that are going on. The only thing that I might change about this is how she's putting her hands, that instead of crisscrossing it like that, making it a lot more superimposed so that the heels of the palm are what is being superimposed, and that'll create more of a compression point than a spread out area. But that's about the only thing. So we talked about the cycle of compressions, that we wanted to perform compressions for 2 minutes long without interruption. And that's because interruptions is bad. Bad as in it takes a little bit of time for the blood flow to build up. Every time you interrupt the compressions, the blood flow that you have created will be paused for a short amount of time, and it'll drop very dramatically. You need to build back up again. So it takes about 60 seconds, we know, for the compressions, continuous compressions, consistent compressions to reach sort of that maximum blood flow that you can create, which is only about 30% of a spontaneous heart. Once you take a little break, it drops down, you have to build it back up again and try to keep it up high. But if you continue to interrupt, it's like you have to listen to the heart or try to intubate. Your doctor pushes you out of the way or something like that. It continues to do this up and down, and you don't quite reach that maximum blood flow that you could reach by doing consistent compressions for 60 seconds or longer. And that's why we say at least 2 minutes before we reassess the patient. So any kind of rhythm checks, listening to the heart, taking a look at the ECG, assessing the patient should be done every 2 minutes. That pause should be minimized to less than 10 seconds. And we use that 2-minute mark to switch out the compressor so that the person doesn't get too tired and the compression quality suffer. Because if you think about the compressions, CPR, it could often be longer than 10 minutes, 20 minutes, 30 minutes. And one person can't sustain compressions through all that, not at all. And even 2 people rotating through might not be sustainable for a very long time. And we found that rotating at least 3 people through 2 minutes of compression cycles is pretty darn sustainable for a long duration. So that's what I would recommend. Okay, so all of that was compressions. Again, compressions is the #1 most important thing, and so we want to make sure that we're performing it properly. The next step is ventilation. And when it comes to ventilation, the one thing that I want to bring up is the timing of ventilation. When do we need to start ventilation? We used to say something like the ABCs of CPR, airway, breathing, circulation. So establishing an airway, initiating breathing, ventilation, and performing compressions to get the circulation going. That's what we used to say. But if you take a look at some of these machines out there, so this is the Dallas airport, that there is a CPR training machine that has the screen. There's a guy that's dancing to Staying Alive and the music's playing, and there's this creepy chest model in the box here that people can perform practice compressions on. Nobody uses this, by the way. But the one thing that I want to point out is this down here. It says hands-only CPR on the go. So it's CPR training that advocates for hands-only CPR, that compressions only is fine. And so there's different kinds of reasons why ventilation isn't thought of as being as important as performing compressions. But with that said, it shows that our algorithm here is no longer ABCs of CPR. It's actually CAB, that we want to create circulation first by performing compressions, and then establish an airway and start breathing and all that. And so we prioritize compressions. We don't stop compressions to intubate, which is something that we used to do. And so for a large dog, for example, compressions going on and intubating them in lateral recumbency while compressions are being performed and without being interrupted is what we recommend now. Now, that can take a little bit of training, and you can definitely do lateral intubation for routine procedures that you can get a better hang of as well. So that's a training opportunity every day. The reason why CAB is what we think about now is that we don't think that oxygen is as important or breathing is as important during CPR because of various reasons. And we don't have to go into the huge details, but basically when an animal is in arrest, they don't need as much oxygen because the body isn't functioning as highly as it normally is. There is some oxygen supply without ventilation because the compression, the change in intrathoracic pressure that we're creating with the compression actually pushes air in and out of the airway as well. And we also know of the severe detrimental effects of interrupting compressions and the lack of blood flow to survival rate. And so we're prioritizing compressions. So when we do perform ventilation, there's a couple of ways that it's done. One is mouth to snout ventilation. The other one is intubated ventilation. Whenever you can intubate, intubation with a cuff is going to be much, much better than doing mouth to snout. But if you are the only person that's there, so you're a single rescuer, or you don't have endotracheal tubes, then you do have to use mouth to snout ventilation. In this situation, you close the mouth with your hands. You cup the nose with your mouth and blow into the nose so that the air goes into, hopefully, the airway. You want to keep the neck straight so that you're not kinking the airway. And if you do kink the airway, it increases the airway resistance, which will make it more likely that the air that you're blowing in will go into the GI tract instead of the airway. And you provide nice, brisk 1 second breaths at a 30 compression to 2 breath ratio. In a veterinary practice, you definitely should have the ability to intubate. So intubating would be much, much better. And in that case, you may end up using an ambibag to provide the breath or even attach onto an anesthetic machine. And so here's a video of that being performed on an anesthetic machine using the reservoir bag. The pop-off is being closed each time you want to deliver the breath to the patient. 10 breaths per minute or 1 breath every 6 seconds. At a 1 second inspiration time. So it's basically counting to 5, 1 second breath, 5 seconds, 1 second breath, 5 seconds, 1 second breath. Now the tidal volume is set to be optimal at 10 to 15 milligrams per kilogram, but that's very difficult to measure unless you have a spirometer or something like that. It's also difficult to attain that tidal volume with chest compressions going on without overpressurizing the lungs. And so we just tend to typically look at the manometer and make sure that we're within 20 to 40 centimeters of water when we're giving that breath. Okay, so all of that was basic life support. So within the first cycle, we should be able to initiate some advanced life support, one of them being monitoring. So a question for you guys regarding monitoring. Which of the following is the best measure for effective perfusion in CPR? Is it palpable pulses, end-tidal CO2, Doppler, ECG, or lactate? All right, so most of you guys are saying end-tidal CO2 or B, and so let's talk about that. So I'll just go ahead and start out by saying that useful monitors doing CPR is in fact end-tidal CO2 and ECG. Those are the two things that will help you during CPR. When we think about end-tidal CO2, we have to think about the respiratory physiology that, I don't know if you guys can see my mouse, but up here, deoxygenated carbon dioxide rich blood comes from the rest of the body, from the tissues, to the alveolus or alveoli, and then comes out, the CO2 comes out into the alveoli. Air moves in and out of the alveoli, taking the carbon dioxide out, bringing back in oxygen rich air, and then the oxygen diffuses into the bloodstream, gets picked up by the hemoglobin, and then goes out to the rest of the body. And that's what normally happens. And so both ventilation, the air moving in and out of the lungs, and blood flow, the blood coming across that blood gas barrier, is going to be important for CO2 to come out and oxygen to get in. So let's see. So ventilation plus perfusion will lead to end-tidal CO2 that's measurable outside of the mouth. Now, the ventilation side should be consistent, that we are breathing once every 6 seconds, 10 breaths per minute. We have just about a pretty similar size of tidal volume that we're delivering as much as possible. And so the rest of what the end-tidal CO2 would be dependent on is actually the perfusion during CPR. So if we're doing good compressions and we're increasing that perfusion or blood flow to the lungs, then we'll get more end-tidal CO2, and vice versa. If we're doing poor compressions and we're not creating blood flow, then the end-tidal CO2 level is going to be low. And that's why end-tidal CO2 can be considered a measure of perfusion to the lungs. It's also useful in confirming endotracheal intubation, that if you had accidentally intubated the esophagus, for example, then you would not get CO2 coming out, and or at least any reasonable amount of CO2 coming out of the GI tract. And so, you know, that having very little or no CO2 reading would make you think about that as a possibility. Now, just because you don't have any end-tidal CO2 reading doesn't mean that you're always in the wrong tube, because it could be poor compressions as well. The end-tidal CO2 also serves as a predictor of return of spontaneous circulation. And we want it to be higher than 15 because there's literature out there that show that end-tidal CO2 of greater than 15 millimeters of mercury is associated with a higher chance of return of spontaneous circulation. So we use 15 as that cutoff mark. It also serves as an indicator for in the return of spontaneous circulation, in that when the heart starts beating on its own, and instead of the maximum of about 30% that you can create with the compression, the heart takes over and creates 100% of that perfusion. Then all the CO2 starts coming into the lungs and out the airway, and you'll get a spike in the ETCO2 reading. So then that's pretty suspicious that return of spontaneous circulation has been achieved. Here's a video of CPR being performed in the monitor that you can see. On the top in the green, you can see compression artifacts that are going on per compression. But what we should be paying attention to is more over here, that you can see the capnograph and the spikes that are following it as compression-induced ventilation. And the number over here on the right side, that says 5 right now, is what we're really paying attention to, which is the end-tidal CO2. 5 millimeters of mercury isn't as high as we want it to be, so we want it to be higher than that. It's gone up to 10, 11, which is better, but still not quite as far as we want it to be. But those are the things that we would look at during CPR. So there will always be compression artifacts when you have compressions being performed, so we can't interpret the ECG during compressions. And during compressions, what's most important is the end-tidal CO2, to make sure that we're adjusting our compression technique to see if we can make the CO2 come up higher than 6, for example. Other modes of monitoring that we might think about, like Doppler or oscillometric blood pressure measurement, pulse palpation, and pulse oximetry, are all things that we think is basically a waste of time during CPR. We're not going to be able to measure a Doppler or oscillometric blood pressure because there's not a whole lot of pulses being created during compressions, and so it's not reliable enough. We can try to palpate for the pulses, but often when we pressurize the chest and there's that backflow of blood into the venous system, and it's hitting up against the valves and creating this pressure within the venous system, it can make the venous system pulsate. And so we may be feeling venous pulsation. Pulse oximetry, we always joke around and say that it doesn't really work when the patient's alive, and so why would it work when the patient's dead? Well, it's because we might have severe vasoconstriction, there's a lot of motion, there's no pulses, and it's really, these pulse oximeters work off of pulses being present for it to be accurate to any extent. And so during CPR, it's not useful. Okay, so let's now talk about vascular access, which should be obtained as soon as possible when a patient's in arrest, and reversal drugs that we might be able to give within that first CPR cycle. So drugs and venous access, we all should have a very well-prepared area for emergencies, whether it's a area that has a crash cart that looks like this with all the drugs and venous supplies in them, or a crash box, which could be a small toolbox that had the minimal supplies within it. And when we think about vascular access, many of you guys probably are very good at placing IV catheters that you can place one in an animal that doesn't have a blood pressure. But in those cases where you can't, having something like this, which is an IO catheter driver, might be useful for adult animals.
Angled more caudally than cranially. And push it through the skin until we hit the bone. And go more or less perpendicular to slightly caudally. Okay.
And so this is called an easy IO. It's just like a electric screwdriver, but it has a needle that you can attach to the tip of it, and it really drills that in. You can see that she was just, Dr. Ellis from our practice, she was just instructionally talking about it, but even then it only took her about 30 seconds to place. In the emergency situation, we have it in the emergency area. We can grab it really quickly, and within 60 seconds or so, or a couple of minutes, we should have vascular access in a patient that has CPR being performed on. When we think further about drugs, there's different kinds of drugs out there that we would use during CPR. And this chart summarizes the drugs that we would use in terms of the arrest drugs up at the top in the blue, and antiarrhythmics in the purple area, reversals in the green area. And we also think of defibrillation as something that is related to a dosage that we would provide, and so that's on the chart as well. And so having a visual aid like this will allow you to very quickly determine how much of these drugs you would be using. And so we talked about administering reversals during that first cycle, and the reversals that we have available to us, at least on the chart, and the common ones that we use is naloxone, which is for opioids, flumazenil, which is for benzodiazepines, and atipamezole, which is for alpha-2 agonists. So we should have all those drugs on board, that if we have anything that could be suppressing the cardiovascular system in any kind of way, or respiration in any kind of way that we can reverse, might as well do that. Then we have the other areas of advanced life support. Depending on the ECG rhythm that we see, we may use defibrillation, we may use antiarrhythmics, or we may be using epi and atropine. And so it's really this area that becomes a little bit more of a diagnostic challenge, in that depending on what we see, whether it's a shockable rhythm or a non-shockable rhythm on the ECG, there's two different things that we end up doing. So we'll start with non-shockable rhythm, which is on the right side over there. If you see, you stop compressions and you see a flat line, this is something called asystole, which is the most common. We just need to continue compressions on this. If we do see this, then the decision that should be made promptly is to continue compressions while we talk about giving drugs. A rhythm that looks like this, once you see a rhythm of any kind, electrical activity of any kind on the ECG, the next step that we should do is to see if there's palpable pulses or a heart that can be heard, to see if this is actual heartbeats that is occurring. If it's not, and it's less than 200 beats per minute, it's considered pulseless electrical activity, that there are electrical activity, but there's no mechanical activity, and it's not creating any pulses. Both of these, asystole and pulseless electrical activity, are considered non-shockable rhythms, and we have to continue compressions to try to recreate that blood flow that we could create with the compressions. In addition, what we would do is deliver the drugs. The drugs that we're talking about is epinephrine or vasopressin. Epinephrine is an arterial vasoconstrictor. It causes peripheral vasoconstriction, which then pushes the blood to the core of the body to more of the vital organs, specifically the brain, the heart, and the lungs that we're worried about. It can be delivered in two different doses. There's a low dose and a high dose. The high dose is something that we consider using when there's prolonged cardiopulmonary arrest and CPR going on, because high dose epinephrine is associated with a higher chance of return of spontaneous circulation, which sounds good, but it's also associated with a low rate of survival to discharge, meaning that when they come back, so much of the vasoconstriction has occurred and there's poor blood flow to the brain, and they may not be neurologically intact when they come back, and so they end up not leaving the hospital. And so the low dose epinephrine is associated with a lower chance of return of spontaneous circulation, but a higher chance of survival to discharge, which means that low dose might be the better way to go. Vasopressin is a smooth muscle vasoconstrictor. It does something similar to epinephrine. One of the benefits that people theorize on is that the vasopressin isn't affected by acidic pH as much, the receptors. And so with prolonged CPR or a highly acidic animal that has metabolic acidosis, for example, might be able to have a better effect than epinephrine. The problem with vasopressin right now is that it's hugely expensive, and most veterinary practices don't carry it, in the United States at least. Apparently it's relatively cheap in other countries though. The other drug that is commonly given is something called atropine. It's a vagolytic, and it is something that doesn't have any evidence that shows that it is beneficial during CPR, but it also doesn't have any evidence to show that it's harmful during CPR, and so many people still give it. And the main indications for its use that we talk about these days is if the patient has reasons to have a high vagal tone, like it's an ophthalmic surgery that the patient was going through and the patient arrested under anesthesia, it's a brachycephalic, it's a GDV, different kinds of things like that that would make the patient be under a high vagal tone, then it might be worthwhile using. All these drugs, we are using when the patient has a non-shockable rhythm, so the asystole and pulseless electrical activity, which means that we can't really make the decision to give the drug until we see that ECG for the first time. So we have to make that rhythm diagnosis before we make that decision. And so that might be something that's different, that we don't just give epinephrine to every animal that arrests. And when we do give it, we give it every other cycle because the half-life is short enough that if we give it every 4 minutes, then it would be just about the right timing. The other branch of that advanced life support section was with shockable rhythms. So a rhythm that looks like this, up and down, irregular and chaotic tracing would be something called ventricular fibrillation. The red one is considered coarse. The lower one is considered fine. And those are both forms of ventricular fibrillation that we might see. The one that just showed up on the bottom could be pulseless ventricular tachycardia, or at least it's ventricular tachycardia. And then when we see any kind of electrical activity that is in repeating manner, then we would take a look at the patient to see if there's a pulse. If there is no pulse, then we can clearly call it pulseless. And if it's greater than 200 beats per minute, it's pulseless ventricular tachycardia. And that's the criteria that we set, that if it's pulseless, there's electrical activity, it's pulseless, and it's less than 200, it's PEA, pulseless electrical activity, that we talked about a little bit earlier. And if we see electrical activity, it's pulseless, and it's greater than 200 beats per minute, then it's pulseless ventricular tachycardia. Both of these are considered shockable rhythms, and so what we need to do is use a defibrillator. So here's ventricular fibrillation showing on a ECG that's attached to a defibrillator. And in that situation, this is what the heart's doing. It's just jiggling. The myofibers are just going off on their own. And the electrical defibrillation shock would then stop those myofibers and hopefully allow the pacemaker to pick back up and start the heart beating in unison again. So that's how electrical defibrillators work. Most of the time, we wouldn't be using internal paddles like that. We would be using external paddles, and we would be delivering that shock from outside of the chest wall, which looks like this. We would take the paddles, we would charge it up to the dosage that we want to, the number of joules that we want to charge up to. The person holding the paddles would ask the rest of the team to help them position the patient in the correct way, which would be in dorsal recumbency like this, so that the paddles can be pushed up against both sides of the chest and pushed pretty hard so that it minimizes the distance between each of the paddles. And then once the person is ready to discharge and deliver the shock, he would say something like clear, and everyone else would back away, make sure they're not touching the the table or the patient or anything like that. The person delivering the shock also making sure that the dog's not doesn't have its leg flopped on its side or him leaning against the table or anything like that. Everyone else says clear, and he verifies that and delivers a shock, and then we go right back to compressions. So the question though is, how many of you guys actually have a defibrillator in your practice? I would assume that the answer is probably only about 10% of us. And so if that's the case, what do you do? There is something called mechanical defibrillation, or the precordial thump, where we just take our fist and slam it down as hard as we can against the chest wall where the heart would be anatomically. And so by delivering a mechanical jolt, we should hopefully be able to do something similar to electrical defibrillation. There's no evidence to show that this is something that is effective or comparable to electrical defibrillation. If you have the ability to electrically defibrillate, then that's the way to go. But I just kind of picture, the whole thing of, and we've seen it work from time to time. Not necessarily getting the patient back, but at least turning it back to asystole. But this is one of those things where you see out in the movies, they pull the person that's been drowning in the water out onto out of the water, and then somebody says, "You're not going to die on me today," and pounds down on the chest, and the person starts coughing out water, seaweed, fish, things like that, and then starts gets back alive. Doesn't work that way in real life. So it is recommended that there is a visual aid, like the algorithm that we have, the drug dosage charts for sure, that is available in the immediate area of cardiopulmonary arrest possibly occurring and CPR being performed. So this is in the anesthesia room, the surgery room, that we have this huge posters on so that we can use it should we need it. Hopefully not, but we might, and also in the emergency areas. So these are posters that are available. You can always print out the algorithm and the chart that is included in the guideline, which is freely available to everyone. And another thing that was brought up with the RECOVER guideline and training material that has been put together is communication. That teamwork and communication is hugely important during CPR. And so it's recommended that clear, direct communication be used through a system called closed loop communication, where people are directly addressing the person that they want to have to do something. So I would say something like, "Hey, Jamie, can you go get low-dose epinephrine?" And Jamie would say something like, "Okay, getting low-dose epinephrine. It's a 25-kilogram dog, 0.25 mLs, 0.25 mLs of epinephrine being given." And then the person taking notes or the leader would then say, "Thanks, Jamie," something like that, so that we all know what's happened and everyone in that room knows what's happened, and that orders are not barked out and somebody thinking that somebody else has got it and not being done. Or if Jamie said, "Okay, getting atropine," or something like that, then somebody would be able to say, no, he said epinephrine. And so then we would be able to course correct and reduce mistakes like that as well. And so in all this, situational awareness and cross-monitoring is important. It's not about being suspicious of somebody making a mistake or anything negative like that. It's just that we all want to make sure that we're doing things correctly, and everyone should know how CPR should be performed and what the protocol is. And so we should be able to correct each other during it for the best chance for the patient to have of coming back. Let's just say that we're able to get the patient back, then we go into post-resuscitative care, or the PCA algorithm. And so this is one more lecture that we could talk about doing. But basically what it comes down to, the algorithm itself looks a little bit complicated and intimidating, but it comes down to three pieces. We want to make sure that we optimize the respiratory system and support it the best way that we can. We support the patient's hemodynamic system so the cardiovascular system is working as best as possible. And we employ different kinds of things that will help the nervous system stay intact. And so that's what it comes down to. So all of that is included in the RECOVER guideline. And hopefully this is something that you knew about or you had interest in, and you are going to put into your practice. And so the question that I have for you guys at this point in time is, has your practice implemented the RECOVER guideline? Seeing yes, 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 no, no, working on it. That's great. Yeah, trying to. Great. Okay. So yeah, so there's a good mix of people. And I think that's why it's so, this seminar or webinar is something that was of interest to people. But it certainly was something that we implemented at Adobe Animal Hospital. This was back in 2012 that we ran into Dr. Fletcher at the Evidence-Based Veterinary Medicine Association Symposium and heard about the RECOVER guideline, and we said, we probably should try to implement this. And this was a 24-hour general/emergency practice. Back then, we had 27 veterinarians. Right now, we have 30, I think, something like that, but 90 technical staff, half of them being credentialed, 3 VTSs. We have emergency, ICU, surgery, different kinds of specialty interests from the veterinarians there and all that stuff. But anyways, it's a 24-hour, pretty large practice. And we had some discussion about how we're going to implement this in our practice. There was some pushback, but we talked through it and we found a way to make it happen. And the main reason that we wanted to implement it was because we wanted to standardize how CPR is being performed. Until then, there really wasn't an official protocol that was established. So depending on the doctor that you worked with, the technicians that were on that team, the shift that you were working on, there were times where it really all clicked together and we got the patient back and it was awesome. But at the same time, there were times where things just didn't click. People are yelling out, things that need to be done. Sometimes, things are dropped, different kinds of things that could go wrong and made it so chaotic that when we didn't get the patient back and that was how CPR is being performed, it made us feel very frustrated, helpless in that situation. And it really wasn't best for the patient, the team, the clients, anyone that was involved in it. And so by implementing that evidence-based guideline and creating a protocol, we thought that we could introduce best current practices that are out there, hopefully make CPR more smooth or simplified in terms of performing. And ultimately, it's about that patient outcome. Did we really do everything that we can for that patient? And will we be able to bring more patients back and send them home? Because that's ultimately what we're interested in, right? And so even though there was pushback and even though there was a lot of discussion about finances and all that sort of stuff that did happen, which I assume many people would run into if they try to do large-scale training in any kind of practice, we were able to do it. And so this is a daytime session where we got a huge group of people. Jamie's in that picture as well. Here's another day session, and you can see that there's actually people working around the training as well because it's 24/7 practice, and we don't close down for things like this. But we did some training. Here's a nighttime training session, so there's a little bit less people. Then we got hungry, so we ate sushi for dinner, which was really good, yummy, yummy. And the result was that we started tracking what our result was. And so the first year, we performed 54 codes and was able to bring 3.7% to discharge. The second year, 28 codes, and we were able to bring 7.1% to discharge. The third year, we did 21 codes, and we were able to bring 14.3% to discharge. And so subjectively, it looks like it's going up. Statistically, because the numbers are so, if we're still talking about 50, 28, 21 codes, we can't establish this statistical significance with this, but it does seem to be trending up. The number of codes going down probably is because we now have a much better handle on which kinds of patients it's worthwhile to try to resuscitate is. And so we have more direct, frank conversations with the clients. And because of that, we have better case selection. And that might be a part of the reason why our success rate is going up. But overall, this is what we're looking at in those 3 years, 6.8%, which is pretty similar to the average that's been reported out there. So the question is, was it worth it? And it's something that one of the practice owners have asked me in the past. And so all I can say is survival to discharge is still low. Return spontaneous circulation rate has gone up. But we also gained perspective on performance too. We didn't know how well we were really doing with CPR. And so by being able to track all that we have a better perspective and we can actually see if we're improving or not improving. And so this is Dr. Johnson, one of the owners that would ask that kind of question. And so I was able to say that it probably was worth it. One of the biggest things that makes me feel that it's worth it is these intangible gains. There's a lot of different things that we changed because of this, but the main thing that I want to give you guys as we're running out of time is that we were able to bring order to the chaos that CPR is. There's less frustrations because of it. We have a better sense of control of how CPR is being performed and what we're actually performing, and that leads to a happier staff. And that alone, I would say, is very much worth it. That we're not questioning ourselves in terms of, man, why did we do this? Why did we try to resuscitate that patient? Or why couldn't we do this better? And walking away in that kind of way. And that's really important. When we take a look at some of the feedback that we got from the staff after the training, there's different kinds of comments that come up. Instead of reading all of them, the last one, I think, summarizes it all. That says, with the new protocol, we're doing the best job possible. Our patients get the best chance. And us being able to confidently say that alone, I think, is very important. And so if we had asked the hospital, and if the hospital could talk, it probably would say it was totally worth it. So thinking about future directions of all this, there is a online set of courses that will start you out in the certification process. And that's located at the recoverinitiative.org website. Where you can learn about basic life support and advanced life support. And even if you don't do anything else, just doing the online courses will very much prepare you for performing CPR with the RECOVER guideline. So it's very much worth it. But there also is an ACVEC approved certification process for basic life support and advanced life support that you can certify yourself in becoming a RECOVER certified basic life support and advanced life support rescuer. And then if you wanted to take the next step, you can become a certified instructor for all this as well. There is a central global registry that's being established so that the same kind of data taking that I showed you with the table that we had, we can bring more numbers in by having more practices participate and submitting data to this registry, which will hopefully lead to the evidence-based veterinary medicine progress itself as well. We're revising the guideline for 2020. And then eventually it should lead to that layman training as well, or pet owner training. Because if you think about the first story that we started out with the trainer being out there and doing whatever that he can, the best that he can with the knowledge that he had in that situation, what if the knowledge was based off of RECOVER? Would our success rate be much, much better in that? And so I'll leave you with this. This is a news story of a pool man finding a ground squirrel in the pool drowning and pulling it out and performing CPR. And apparently the heart is in the abdomen for ground squirrels because the animal comes back. And so I don't think we'll ever get to the point where we say, here's the evidence-based RECOVER guideline for ground squirrel CPR or anything like that. But we are adding for the 2020 cycle, large animals, neonates. We had some conversations with somebody that worked at a zoo that is joining in on the large animal side so that at least they can give insights regarding some of the larger animals that they have. And we'll continue to work on gathering more evidence and even producing more evidence. That RECOVER has put out a CPR-related research grant with the funds that we've gathered. And so this is all a nonprofit endeavor to try to make veterinary CPR more and more successful within the veterinary field. So one of the common pushbacks that we might get regarding trying to talk about training people on CPR is, well, success rate is so low, why even bother? It's only 6%, it's only 2 to 7%, whatever it is. And what I would say to that is this quote right here, that saving one dog will not change the world, but surely for that one dog and their family members, the world will change forever. What if it was that routine surgery, spay that came in and the patient arrested and you don't know how to perform CPR? Can you explain that to your clients? And so because of those reasons, I think that every veterinary professional should know how to perform CPR the best way possible, which is what RECOVER is. All right, thanks everyone.
Ken, thank you so much. I really appreciate it. And that was awesome. We're a little bit over time. For those of you who need to jump off, you can totally do that. We're going to answer a couple of questions real quick. Ken, you've got a few minutes?
Yep.
Fantastic. So I'll go ahead and jump in on the questions. Stacy had a question about how long do we do CPR before we call the time of death on average if there are no responses noted with CPR?
Yeah, and that's a hard one because we can't really draw we should perform CPR for this long for every patient kind of thing. It really depends on the patient's situation. If it's a patient that is geriatric, 16 years old, has certain organ failures, and that's why they arrested, then it's probably not going to be a case that we would think trying for a longer amount of time is going to make that difference. Whereas if it was one of those younger animals came in for a routine procedure, was healthy otherwise, it might be worth trying longer on. The other thing that we tend to take a look at is how well the CPR seems to be going. That if the end-tidal CO2 number is staying up high and we're able to create good perfusion, then it's more likely for this patient to come back when you go for a little bit longer. Whereas if it's a patient that you're having trouble bringing the end-tidal CO2 up on, then going longer may not be what makes that difference. And so there's different kinds of things to consider like that. But with that said, on average, CPR could be performed anywhere from 10, 15 minutes to even 30 minutes.
Got it. And in human CPR, you no longer provide breaths, and it's considered sufficient enough to only provide chest compressions the entire time. Why are we not crossing this over into veterinary CPR?
Yeah, and so it would be interesting to see how the 2020 revision of the guideline might change things because let's see, the American Heart Association guideline was published, and then it went through one revision or something like that, and then the RECOVER guideline was published, and then another revision of the American Heart Association guideline came out, which introduced this concept of hands-only CPR. And so then after that is where we're revising the guideline to now. So different kinds of evidence might come into play. The guideline may change a little bit. There's also other reasons why hands-only CPR is being promoted on the human side, that when they took a look at some of the reasons why people weren't jumping in to perform CPR as a bystander was because they felt like they needed to do mouth-to-mouth breathing. And some people felt a little bit weird about that. They were worried about infectious diseases, different kinds of reasons that come into play that it was favorable to take that out or encouraging just hands-on CPR would make it more likely that people would jump in as well. And so there's different kinds of reasons that came into play. With that said, 2020, when the new RECOVER guideline gets published, let's see what it says.
Got it. What about in assigning roles? Jennifer wants to know, in a large practice, do you recommend having people with designated roles each day or having them jump in at random? For example, if Lisa's always the supervisor and Andy always gives the drugs.
Yeah, so depending on the team, I think that there are some practice settings where designating roles and that being consistent makes sense. So it's a small enough team and you have the consistent people that are on. At a practice like ours where we don't know who's on at what point in time in any kind of consistency, instead of setting up different kinds of roles or even setting up a designated CPR team that functions during the day, we just train people who can be designated as leaders, people who can perform CPR, and we just call a code, and whoever arrives on scene gets to form that team and do what they need to do as quickly as possible. And that's to eliminate the situation where pieces of that team is missing because they're in the middle of something when the code is called for. So I think it'll depend on your practice setting and what protocol you want to put in place.
Got it. And question about defibrillation. Can people actually touch the dog like was shown in the picture?
No, that picture was showing the dog being positioned in place for the defibrillation to occur. When the shock is delivered, before that, the person would call clear and make sure that everyone has backed away and they raise their hands and everyone's looking around and making sure that nobody's touching anything, for sure. that was not the photo of the shock being delivered. It was the photo of the dog being positioned.
Perfect. Thanks for clarifying that.
Thank you.
Erica has a great question about codes and nomenclature. There are a lot of things going on like CCPR, OCCPR, DNR, BLS, ALS. Do you think that this is getting confusing? And what's the best way to make sure that people are knowing what's going on?
Yeah, I think that between CPR and BLS and ALS, like basic life support and advanced life support, it's probably easy enough to just call it all CPR, and then the veterinary professionals know the difference between BLS and ALS and things like that, then that's okay. In terms of the terms like CPR and CPCR is probably something that's out there pretty commonly. So instead of cardiopulmonary resuscitation, it's cardiopulmonary cerebral resuscitation, including the brain. So that's a term that has been introduced over the course of history, but the RECOVER guideline actually specifically has stated, at least during the drafting process, that because CPCR stands for something else in the human medical field and they basically mean the same thing, they try to eliminate that confusion by standardizing to CPR. So we call it CPR now.
Got it. Jessica has a question again about assigning roles. So let's talk about a small practice. I know, Ken, you've never worked in a tiny practice, but let's pretend that you work in a small practice and there's only 2 to 3 staff members on. How would you assign roles in that situation to maximize efficiency?
Yeah, that's a realistic challenge. And so basically there's about 5 or 6 roles that we need to cover in CPR. The person doing the leading, person doing the compression, person doing the ventilation, person delivering the drugs, and person recording. That's 5. And so when you think about the person doing the leading and recording, for example, those two probably could go very easily together. You can even add on the drug role to that person so that one person can cover 3 roles. Then it's ventilation and compression that needs to be done otherwise. And so the person doing compression and ventilation could switch in and out during each compression cycle, and you have 2 people rotating through. You can try to implement a 3 people rotation with the 3 people that you have, but I'm a little bit worried about the person doing the recording switching around, because oftentimes people can't read each other's handwritings or don't know exactly that person's system in terms of recording. And so when they're asked, when was the last epi given, they might not be able to quickly find that. And so keeping the recorder consistent is something that I think is a little bit beneficial, but it really depends on how standardized your recording system is during CPR. If you only have 2 people performing CPR, yeah, that's tough. That is tough. And so then that may end up being that the person performing the compression just needs to focus on performing compressions, because you don't want to interrupt that in trying to grab the monitor or give a breath in between or anything like that. And person delivering the breath would have to give a breath, go grab whatever they need to grab within the 5-6 seconds, and then give a breath, and then go do the next thing, and then give a breath, and then go do the next thing, and such. And then everyone being able to think through that. The ultimate thing would be if you are in a situation where you are likely to encounter cardiopulmonary arrest in any kind of way, probably want more than 2 people around.
Perfect. Do you practice, well, we know that our practice collects a CPR status on all of our anesthesia patients and our ICU patients, but we definitely don't do it on all of our patients. So Kate wants to know, do you recommend that CPR statuses are collected on all patients? And what about the idea of offering some sort of minimal basic life support to patients as an alternative if we don't ask?
I think that as veterinary medicine and veterinary healthcare develops, having a resuscitation order for all your patients is probably something that is would be recommended, at least for patients that are going to be hospitalized, that are going to have anesthesia performed. Some practices even go the length of having a resuscitation order, or at least encouraging a resuscitation order being developed for any animal that comes into the practice. Our practice didn't go as far, but our practice at least got the resuscitation orders for patients that are being hospitalized and patients that are being anesthetized. And the reason being, different people have different beliefs. And so even if you say that by default, we're going to perform the most basic level of CPR, it could be something that they don't believe in. So asking that question ahead of time is probably the best thing to do, being respectful to each of those families' wishes.
Yeah, I think it's a tough one. And having had the experience of being with family members in the hospital and needing to have answers to those questions, I think it's really important. We've got a couple more questions. So let's talk real quick about low dose versus high dose epi use again. Can you go over why one is more preferable than the other?
Normally, we start with low-dose epinephrine, and that's because even though low-dose epinephrine is associated with a lower chance of return of spontaneous circulation, it's associated with a higher chance of survival to discharge, ultimately surviving. And high-dose epinephrine is something that on the algorithm, if you take a look at the chart, will say with prolonged CPA, consider using high-dose epinephrine. And most people draw that mark at the 10-minute mark. Basically, if you use high-dose epinephrine, you may very well get the patient back because it's associated with a higher rate of return of spontaneous circulation, but it's also associated with a lower rate of survival to discharge, likely because it causes tissue ischemia and with the vital organs. And the patient, after surviving the cardiopulmonary arrest and the heart's beating, the patient's brain may be dead, basically. Or they may have multiple organ damage that leads to multiple organ dysfunction that they don't ultimately survive.
Got it. Thank you. And this is something that it didn't come up in the last one, but is usually a standard question that gets asked in CPRs. So let's talk real quick about rib fractures and the risks. How often do we see it? And how do we answer those questions from owners?
Yeah, so CPR and performing chest compressions specifically is something that can cause damage to the animal for sure. That could be rib fractures, it could be fractured liver, spleen, different kinds of organs that are underneath the rib cage that's being sort of pounded on. And so it can cause damage. The risks are apparently relatively low, but with that said, it can happen. And specifically for rib fracture, what I have heard in the past is people saying that if you don't break the ribs, you're not pushing hard enough or something like that. And I disagree with that, that you can definitely, as you're performing compressions in the way that you think you should be, the ribs can fracture, but that is not the goal. You want to be pushing hard enough to create that compression of the chest and the full recoil and creating the difference between the interthoracic pressure. But if you think about the rib cage and the recoil happening, if you break a rib, there's less recoil. And performing compressions once the rib hasn't fractured would probably make it more likely that the organs underneath it would get damaged. So anyways, the point is rib fractures can happen. If it does happen, it's important that you don't blame yourself for it. When you're pushing hard enough that you can depress the chest in the manner that we say we need to, it can break. but don't push so hard that you don't be going like, the rib's not breaking, I got to push hard enough. Take a look at the end-tidal CO2, perform compressions with the technique that we talked about, and that's what you should be basing your strength of compressions on. But damage can happen, but it's not your fault.
Got it. Thank you so much for that, Ken. And as a reminder to everybody, we will be sending out a recording of this. We have a couple more questions to go over, so we're going to hang out for just a little bit longer. But RECOVER is teaming up with NAVTA, as you've noticed, for our webinar. But NAVTA members are going to get a special discount of 30% off RECOVER online courses at recoverinitiative.org. You can find the code behind your login at navta.net. So check that out. We'll also send that out as a reminder in that email that you're going to get with your recording. And again, your CE certificates will be out in about within the next week. And if you did call in, please do email me at veterinaryce@gmail.com so that I can get you on the list with match up your phone number with your name and email address. So Jacqueline wants to know, how is it safe to go over 20 centimeters of water for ventilation pressure? You said it was 20 to 40. How is it safe?
Yeah, so it's counterintuitive, or it's like we have this natural resistance to that, right? Because we're always told that we never go above 20 centimeters of water when we deliver manual breaths, and totally get that. For any healthy animal that you are sighing during anesthesia, there's no need to go over 20 centimeters of water. In a CPR situation, when there's compressions going on, the pressure might be a little bit difficult to control. And so I'm just saying, give yourself between 20 and 40 centimeters of water. And going at 40 centimeters of water for a short-term duration isn't something that is going to be detrimental to the lung tissues as much as we think. If we take a look at the ambu-bags that are out there, there's a safety valve that prevents pressurization of beyond a certain pressure, and that safety valve is set for 40 centimeters of water because that's considered the danger point for people. And so just thinking about it in that kind of way, during CPR, you have an ambu-bag that is 40 centimeters of water and you're trying to provide good breaths, then we just go ahead and give that. But don't go 40 centimeters of water for your patients under anesthesia, please. That's all I'm saying.
Excellent. And for our final question tonight, Ken, if we're not pausing compressions for respirations, what sort of rhythms do you do, if any, between compressions and breaths?
Yeah, yes, we are not trying to time breaths in between compressions at all, because that can alter the rhythm of the compressions. The person performing the compressions should consistently keep it within that 100 to 100 compressions per minute and just focus on that. The person doing the ventilation also needs to just keep that 10 breaths per minute once every 6-second rate, because consistency in ventilation is something that is important to keep the end-tidal CO2 more accurate in that situation. So if we tend to hyperventilate, then we blow off more CO2 and we might create an artificially lower number. Whereas if we hang on to it more and we do slower breaths, then it could artificially increase the end-tidal CO2 in that situation. And it might not be accurate as an indicator that we're looking at in terms of the compression effectiveness. And so with all that in mind, using the ambu-bag probably is a better way to go during CPR, that the compressions are going, you're just giving the breath whenever and allowing the safety valve to vent the pressure out if the compression is going down and the breath being pushed in happens simultaneously.
Perfect. Ken, thank you so much for taking the extra time with us tonight to answer all of our questions. Thank you everyone for being here. A big chunk of you hung on for the very end. So thank you so much for being here. Everybody have a great night, and we really appreciate it, and go out and do good work and have happy holidays. Thank you so much, everybody. Good night.
All right. Thanks everyone. Have a good night.